Good morning and welcome to your 11 a.m. Track 1 session. Thank you for joining us. And today we have Dr. Adil Daud and Dr. Justin Moser discussing how to navigate melanoma, uveal melanoma metastatic diagnosis. So let me introduce you to the speakers. First up, we'll have Dr. Justin Moser. He's with Honor Health Research Institute. So Dr. Moser is a medical oncologist who specializes in phase 1 clinical trials, drug development, and uh, cutaneous malignancies. He leads the melanoma program at Honor Health Research Institute and runs one of the only programs dedicated to uveal melanoma in Arizona. And we're grateful to have him here. I'm also going to introduce Dr. Daud, and he's going to be with us here shortly. He is of UCSF, and he's a medical oncologist specializing in developing novel immune and targeted therapy for melanoma. He has extensive experience in translational research, clinical trial design, especially in melanoma, and we're grateful to have them both. So Justin is here with us live. Thank you for Dr. Moser for being here, and let's go ahead and get started.
Great. Well, welcome everyone. As I mentioned, I'm Dr. Justin Moser, and I'm at Honor Health Research Institute in Scottsdale, Arizona. And today we're going to be talking about navigating a diagnosis of metastatic uveal melanoma. Adil should be on shortly. We'll kind of talk about different things back and forth and then have some discussion questions. Some questions were commonly asked that there's some answers to, or there's answers to, but not always one answer. So we'll kind of discuss back and forth to try to give kind of a comprehensive overview. But first we'll get started with some short slides about general navigation tips, as well as some discussion on systemic therapies and local therapies for metastatic uveal melanoma. So some general comments about navigating a diagnosis. The first thing is, use the patient advocacy groups. And we don't necessarily have to tell you guys this because we're here at the Cure Insight Patient Forum, but these groups are very great. They provide a ton of information, a ton of support, and they have a lot of materials that can help educate patients and their families about this, more rare disease and how it goes. I've also had a lot of patients find a lot of comfort in connecting with other patients with metastatic and then primary uveal melanoma by going to the Facebook page or the other social media pages of the patient advocacy groups, such as a Cure Insight. And some of them even meet up for lunch every couple of months just to kind of talk about stuff, and talk about stuff, get information, and kind of work through their mutual feelings and struggles with this rare diagnosis. The second point I want to make is find or coordinate your care with a medical oncologist who has expertise in uveal melanoma. Medical oncology is a field right now that is exploding. I think 5 or 6 years ago, we really had, a couple of treatments for melanoma. Now we have a handful, and other cancers like lung cancer, we used to have 2 or 3 treatments, and now there's 15, if not 20 different treatments that are available. And so medical oncology as a whole is becoming very complex. And people who do general medical oncology really, it can be really hard to stay on top of rare diseases that they don't see frequently, such as uveal melanoma. So make sure you connect with a medical oncologist who's experienced in uveal melanoma and is up to date with the changing landscape. Sometimes, there's just not one in your area. There's not a medical oncologist who has seen a lot or is experienced in uveal melanoma, and that's okay. And then I think coordinate your care with that medical oncologist. If that's flying to do an in-person consult one time with someone who is experienced in uveal melanoma, who's willing to work with your local medical oncologist, that's great. A lot of states are still allowing across state line video visits. And so maybe it's a video visit with, myself, Dr. Daud, or one of the other many medical oncologists who are specialized in uveal melanoma, who are willing to coordinate and work with your local medical oncologist. The next point is that second and third opinions are okay, and they are welcomed. But the one thing I always ask is, you discuss this with your primary medical oncologist, and that's because a lot of the times we're talking behind the scenes. Just a couple months ago, I had a patient tell me, or cancel their appointment with me and reschedule a week later. When I saw them in clinic, they informed me that, they had actually flown across the country to another medical oncologist to see if they had clinical trials. And when they found out they didn't, they came back to start treatment with me. And, I was upset to hear that because 2 weeks beforehand, I'd actually had a research meeting with the same doctor that they met, and I had discussed and asked, do you have an option for this patient? Because I would have told the patient and sent them there. And so a lot of times we are talking behind the scenes and trying to figure out what is the best option. So just ask us, work with us, because we may know if an organization or another physician has a trial or better option for you. We may not. So you may end up going otherwise, but it's always nice to not have to take the time off work or buy a plane ticket or fly across the country if we've already discussed and reached out to that physician. The next one is send genomic testing on the biopsy from diagnosis. So genomic testing is a newer test that we're doing in oncology, and it's where we test all of the DNA and all of the RNA to look for any genetic mutation that the tumor has gathered. We do this because it can help sometimes stratify the risk, but it can also sometimes identify treatment options and specific targets or help guide us towards better clinical trials. And anytime we're dealing with these rare cancers or when we're running out or have limited treatment options, it's always important to have the most information possible and the best understanding of one's cancer. So make sure we're sending that genomic testing on the biopsy from diagnosis. That way everything's kind of moving quickly and we have all the information so we can start treatment. The last point, which you'll probably hear more about during the conference, either today or yesterday, is now we need to send germline HLA testing. So HLA testing is important because the new medication that will likely be FDA approved soon, tebentafusp, is only an option for patients with a specific HLA type, and that's HLA A0201. This is present in about 30 to 50% of patients, and so we need to send this early so we know if you're a candidate for this treatment option. Sometimes some companies are reporting HLA types based on the tumor sequencing, and this can be helpful because it may give us a quicker answer, but it's still important that we always send the germline test. When we take a tumor biopsy and try to test the HLA of the person and not the tumor, it's not 100% accurate, and that's because cancers become cancers because their DNA changes from what you were born with to something different. And so there's a possibility that we may not be able to get, or that HLA of the tumor isn't that of the person. And so we always need to make sure we send germline, even if another test from the tumor is going to report the HLA test, because it affects treatment options, and so we don't want to miss it. So now we're going to transition and talk a little bit about some high-level things in terms of local therapies for uveal melanoma. And then when we're done, Dr. Adil will make some comments about systemic therapies and other things about navigating metastatic uveal melanoma. So as most of us know, in patients with metastatic uveal melanoma, about 90% of them, if not more, will have liver metastases. And for many patients, this may be the only site of disease. Because of this, liver-directed therapies are a reasonable option for some patients, and liver-directed therapies are really the therapies that target a specific treatment to the liver rather than giving something either orally or through an IV that goes everywhere throughout the body. And we don't actually know what is better right now, liver-directed therapies or systemic therapies. There's no data directly comparing the two to tell us if one is better than the other. We did have a meta-analysis that was published a couple years ago that suggested maybe there's a small improvement in survival for people who get liver-directed therapies as compared to systemic therapies. But there's a lot of caveats to this. This meta-analysis included trials of treatments that we currently no longer use. Usually right now for metastatic uveal melanoma, we're doing immune therapy-based treatments. Most of the trials included in this meta-analysis were before those times. And so we don't actually know if this is true anymore with the current treatment landscape of metastatic uveal melanoma. The other thing is that this may be due to patient selection. We all know that the natural history of uveal melanoma is it starts in the eye. if it spreads, it tends to go to the liver, where it can grow and then spread elsewhere. So if we look at patients where the disease is only in the liver and hasn't spread elsewhere, those would be the patients who got liver-directed therapies, and compare them to the patients who got systemic therapies. Presumably many of them had disease that had already spread outside the liver. There may just be a difference in that regard. And so I think right now most people would say that we don't know what's better, liver-directed therapies or systemic therapies. But for patients with liver-only disease, liver-directed therapies may be an option. But this is based on a discussion with you and your doctor and trying to figure out what the best thing is for you as a patient. And that's looking at the risks, the side effects, the outcomes, and how the different treatments, how involved the different treatments are, and how they affect your life and quality of life. There's two main categories of liver-directed therapies. One is transarterial embolization. So this is where an interventional radiologist goes in through the artery in the leg, finds the artery that feeds the liver, and then they drop beads that block the blood vessels to the liver. And they either add chemotherapy to that or radioactive beads. Chemotherapy is currently only offered, I think, at a limited number of centers. The radioactive beads are more commonly used. And again, we've never compared them head to head, so we don't actually know which one's better. So it's really just a discussion about what's available and what's the best option for the patient. The second big type of liver-directed therapy is percutaneous hepatic perfusion. So this is something that is currently being studied. We recently got some data about a phase 3 trial using percutaneous hepatic perfusion in patients with metastatic uveal melanoma. That was presented at ASCO this year, our large cancer conference. And it is being offered at a few sites in the United States as standard of care currently, while we're waiting for that definitive final outcome of the trial. So what is percutaneous hepatic perfusion? So this is it's a minimal but fairly involved procedure where the interventional radiologist goes in through the blood, or into the blood vessels through the legs but this time they go into the vein. They go into the vena cava, which is the big vein that runs through the abdomen and the chest and brings all the blood in the body back to the heart. And they actually place two balloons, one above the liver, one below the liver. And that cuts the body into two different circulations. There's the artery and the vein that feed the liver, and then the circulation of the rest of the body. They then connect the artery and the vein of the liver and hook it up to a machine, creating a separate blood flow system for the liver. Now that they've done this, they can actually circulate high doses of chemotherapy, which is typically melphalan, through the liver. And this allows them to give higher doses of chemotherapy than typically we're able to do through an IV, but also concentrate that where the cancer is, which is in the liver. And in the initial reports of this study that were reported in June of this year suggest that maybe 1 in 3 patients will have their disease respond to this treatment, which is a very exciting response rate. We're still waiting, though, for the full data of the trial to be reported before we know if this is a great option for most patients. Okay, and with that, we will jump over to Dr. Daud.
Good morning. I'm excited to join you, and thank you for that very nice presentation, Dr. Moser. So I apologize for a somewhat lengthy presentation, but I'll try to get through it in sooner if possible. Next slide. So as Dr. Moser was saying, uveal melanoma is pretty uncommon. However, it has this problem that it has this delayed and persistent metastatic kind of recurrence pattern, and it can arise in any part of the eye. It can arise in the front part of the eye, in any of the pigmented part of the eye. Next slide. And so one of the things to look at when you have a diagnosis of uveal melanoma is to look at CAT scans and PET scans. And these are types of scans that are done uh, in, uh, in medicine commonly, and they have different types of utility. But oftentimes we'll do either one of these types of scans in somebody who has melanoma. And this is a patient with non-uveal melanoma, just showing the sugar uptake that's characteristic, and that shows the presence of a cancer on a PET scan, like here in this case on somebody's thigh. Next slide. And so, to take up with what Dr. Moser was saying, multiple types of treatments have been tested in uveal melanoma, and they've had relatively modest success, I would say. And we heard about liver-directed therapy, but other types of trials have also been ongoing in melanoma. Next slide. And this is a slide that was presented at ASCO 2016, and then just looking at a series of trials that were done, and you'll notice that the response rate was roughly in the 10% range. So not the greatest degree of response. Liver-directed treatment had much higher response rates. Next slide. Next slide. And let's keep going. Keep slipping over. And so the one trial that was done a few years ago was of a MEK inhibitor called Cellumetinib. And it's kind of an interesting story where it did show uh, some uh, progression-free survival benefit versus temozolomide, which was an older chemotherapy drug that was used. But then when it was tested in a randomized trial, basically there was no real benefit, as you can see on the right-hand side. If you can see that really did not show much of a benefit, and today it isn't used. Next slide. Uh, I'm going to skip over this in the interest of time. And so when the PD-1 drugs were introduced into melanoma, there was a lot of interest in looking at it in uveal melanoma. And my colleague Alan Al-Ghazi looked at data for Pembro, Nivo, and Atezo clinical trials. And basically what he found was, and that's been my experience too, that the response rates were really modest. So like 4% in our review, and some other, like Mayo Clinic had reported 30% response, but now we think that that's probably an outlier, and probably just reflects a small number of patients treated at the Mayo Clinic, but overall the response rate is probably in the 5% range. Next slide. Next slide. So what the thinking today is that in many cases, tumors do induce some type of adaptive immune response, and this is a figure that I put in a recent review. People think that when cancer is present, your immune system senses it, and dendritic cells, which are specialized immune cells, uh, sense the presence of the cancer based on certain inflammation markers and certain proteins and RNAs that are secreted by the tumor, and then these DCs go to the local lymph node and then lie in wait to find the right T cell. However, the problem with this picture is that you need to have immune sensing of the cancer. And we think that in uveal melanoma, because of the low mutation rate and because of the fact that it's in the eye, which is a part of the CNS, or central nervous system, that's shielded from the immune system, you don't really have that type of immune sensing. Next slide. And next slide. And so what people have figured is that because of that lack of immune sensing, maybe what you need to do is to use a different approach. And one interesting approach has been to use tumor infiltrating lymphocytes. And this was a study done at the National Cancer Institute by Uday Kamula and Steve Rosenberg and colleagues, and actually showed a pretty interesting response rate, 35% response rate, which is more than has been seen with checkpoint immunotherapy anyway. But I think there's some questions about how much these patients were selected and whether this is reflective of the general experience with TIL therapy. Next slide. And the other major advance in our field is this drug relatlimab, which is being tested in your garden variety standard melanoma. Next slide. And next slide. And this was the trial design that was just presented recently, where it was combined with nivolumab, relatlimab, or Rela, was combined with Nivo, and compared to Nivo alone. Next slide. And the blue progression-free survival bar is the Rela plus Nivo arm, and the green one is Nivo alone. And you can see that there is a difference. There's maybe about an 11% difference in progression-free survival at a year, and it seems to be somewhat persistent, and that translates to about a 25% benefit for Rela plus Nivo versus Nivo alone. Next slide. Next slide. And then, of course, you know that Nivo plus ipilimumab has some benefit in melanoma as well. Next slide. And recent data has indicated that if you do have a benefit from the Nivo plus Ipi, that benefit does, and then that's in this orange line here, it does seem to be sustained. So you could see that at 60 months, which is 5 years. You could see that at 6 years. You could see that at 7 years, which is 84 months. So it does seem like once you have a response from immunotherapy, many of these responses can last years. Next slide. And so based on all of this, there's this drug called tebentafusp, which is a really very interesting class of drug that's being tested in uveal melanoma. And the thinking here is that we don't know surface proteins that are specific for uveal melanoma cells, but we do know uveal melanoma makes a lot of GP100, makes a lot of melanoma-specific proteins, and those proteins are displayed on the surface bound to a molecule called a human leukocyte antigen, or HLA peptide. And so you could target that. Next slide. And so this just shows that example. So like if you look at a melanocyte, it expresses some GP100, but uveal melanoma specifically expresses a lot of GP100. And so the thinking is you basically bind to the HLA expressing the GP100, and then you have this molecule that has a T cell binding, like an HLA binding domain, and a CD3 binding domain, which basically brings your T cells close to melanoma cells. And so it's a bispecific TCR fused to an anti-CD3 molecule. Next slide. And that molecule essentially brings your kind of lassos in your T cells and brings them close to your melanoma cell, which may be in the liver, which may be someplace in the body. Next slide. And so this was the design of the trial. You had to be HLA-A201 and no prior liver-directed therapy except surgery. Patients were randomized to tebentafusp versus investigator's choice. You could have anything else. Next slide. Next slide. Next slide. Sorry, prior slide. Okay, and basically that's what it showed, that if you looked at overall survival, the tebentafusp patients had a much better overall survival as compared to immunotherapy or investigator's choice immunotherapy, which was in the green arm. Now you'll notice that unlike some of the other slides that I just showed a few minutes ago, there doesn't appear to be a flattening of the curve. So you could see that patients continue to have survival uh, decrease. And so I think there's a lot of active research right now on trying to improve tebentafusp, or maybe to apply the same principle to other types of proteins that might be specific for uveal melanoma. So with that, I'm going to stop and then maybe start with our discussion, just because, just in the interest of time. But I think this does illustrate the issue of maybe a new era of immune therapies could be starting now, that we didn't even think could be possible for a tumor that doesn't have a lot of mutations, and for a tumor that doesn't have a lot of T cells within it. So thanks for your patience, and I apologize for all those numerous slides. Uh,
Thank you, Dr. Daud. Fantastic presentation. I know it seems like it was long, but it really wasn't that bad. It was great. So thank you very much. And thank you, Dr. Moser, for your presentation just prior to that. We do have some questions coming into the chat. And so the first one we have is from Dina Nugent, which is it normal to spread to the bones as well as the liver and the lungs?
it's common. I mean, in uveal, I'll be interested to see what Dr. Moser's answer is, but it's the most common size. 90% of the time is in the liver, but also bones and lungs are another site where uveal melanoma can spread to. Not the most common site, though. The most common site is the liver.
Yeah, I agree. If it spreads outside the liver, we tend to see the lungs and the bones involved fairly often, but the liver is by all means the most common and typically the first place we see it.
Hmm. Okay, thank you for answering that, and thank you, Dina, for sending that over. And we have another from Val Christ. Why have I heard that chemo doesn't work with UV and yet it's used as treatment?
Is that, I'm assuming that question is in response to the partial hepatic perfusion that we talked about, where they infuse the chemotherapy, the melphalan. If that's the case, chemotherapy, it probably would work in uveal melanoma if we could give high enough doses, right? For chemotherapy, it's all about how high of dose you can give. And with the number of doses, or with the amount of chemotherapy or the dose of chemotherapy that we can give through an IV, we would do more damage than would be helpful. That's why if we do something like partial hepatic perfusion and we can circulate higher doses of chemotherapy directly to the liver and not to the rest of the body, we may be able to safely give a high enough dose that could be beneficial. We just need to wait for that trial to kind of report its final results before we actually know if that's true or not. But that's kind of the logic behind it. It's selectively giving a high enough dose to one location versus everywhere to spare side effects.
Dr. Daud, do you have any comments on that one?
Yeah, no, I think I totally agree with that. That in the era of immunotherapy, what's turned out in the case to be the case in, like, for example, lung cancer, which can be, lung cancer comes in two varieties: smoking related and non-smoking related. And in the past, the smoking related cancers were actually somewhat more difficult to treat. But with immunotherapy, it's actually paradoxically easier to see responses in smoking related cancers, because smoking causes you damage, DNA damage, and that DNA damage produces what we call neoantigens, or basically abnormal proteins that are produced by your cells that can be recognized by your immune system. So in a weird way, the smoking related cancers actually seem to be more responsive to immunotherapy. Now, with uveal melanoma, even though we think, we still don't have a great idea of how it's caused or what sets it off, and the mutation burden, what's known as mutation burden, is very low in uveal melanoma. Most studies have found barely any mutations. uh, I think this idea of roping in the T cells and then just physically bringing them close to, uh, the tumor cells, I think that approach does seem to work to some extent. And so I think I think there's a question about what to do if you're HLA negative. So what HLA negative means is not that you literally don't have HLA. It just means that you don't have that HLA A201 locus that about 50% of Americans have. But that still doesn't mean that you're negative. It just means that you have different loci, maybe not as common as the 201, but but maybe 10% of Americans will have those less common loci. So I think what could be done is that we could have tetramers just like tebentafusp, but specific for, let's just say, 301 or different HLA types linked to the same CD3 antibody, and that would still rope in T cells. It would still, your immune system still works. You just don't have that uh, one specific. So it's like saying, if you have a rare blood type, it's not like you can get a transfusion. You just can't go to, you can't just expect that a blood bank will always have your blood in stock. You might have to order it
Mm.
from a different blood bank that keeps, I'm sorry that this is not a great example, but you, now that the concept is clear, I feel like we could easily make uh, drugs that work for less common HLA types.
Mm. Thank you so much for sharing. That was fantastic, and that was a question submitted by Suzanne. So thank you, Suzanne, for sharing that. We have another question from Rob Spence, and it says, "How common is HLA germline testing, which is new to him?"
Yeah, it's very uncommon. I don't think we send HLA germline testing for any other cancer type at this point in time. As Dr. Daud said, the new drug tebentafusp was specifically designed for patients with HLA-A0201. But I think now that we have that kind of proof of concept that this can work, as we get more drugs, it might become more common. But right now, I think the only cancer that treatment options may change due to the HLA is uveal melanoma. So really, I think most people, or at least oncologists, if we're sending it, we're sending it for uveal melanoma patients. Typically these are sent for organ transplant patients because HLA is the kind of blood type that you need to match for organ transplant. So typically outside of transplant, we're not sending it outside of uveal melanoma.
Yeah, thank you so much. Thank you so much. And Rob, we hope that answered your question. And Valchrist has another question. It says, "Is Tebby used only in case of Mets? Any studies where it's used more as a preventative adjunct therapy?"
It takes a while to show the benefit of treatments in as preventive adjunctive therapy, and that's because those trials are much longer running and much more complicated and difficult to do. And I think the further problem in uveal melanoma, as you guys all know, is that once you have met, the immune system can actually get to them. When you have uh, a uveal melanoma that's in the eye or in one of these restricted places, it's actually hard for antibodies to get there. So, and tebentafusp surprisingly does not work well in garden variety cutaneous melanoma, which is kind of surprising because they also have GP100. They're actually have a lot more immune cells, and so we don't fully understand why it's so specific for uveal melanoma in the liver. But if I had to, I mean, I just putting on my blue sky kind of hat, I do think that that same mechanism probably will work in the preventative setting. We just don't fully, maybe not that tebentafusp molecule, but maybe slightly modified uh, you know, molecules. I think, just to take a step back, one of the other problems with tebentafusp is that it has to be given weekly, and it causes, what is known as cytokine release syndrome, meaning like you have fevers and chills, and you have some lowered blood pressure each time you get an infusion of tebentafusp, and that generally happens because the half life is really low, and so people are trying to make a form of it that's longer acting and doesn't have some of those side effects, and it could be that slight some modifications of it could get into the eye or could get into places where it could have more use as a preventative treatment. And I know Dr. Moser has some thoughts on that too.
I agree. Adjuvant trials are much harder to do than metastatic trials just because, it takes so many years to figure out if it actually reduces your chances of this coming back at 5 years, right? We have to follow people for 5 years, so it's much slower. But then we also have that kind of dilemma that, Adil kind of alluded to, which is in the adjuvant setting, there's a proportion of patients we're treating that are cured. And so we don't want to give someone a drug that is given weekly, that you have to be in the hospital, that can cause significant detriments to quality of life because you may already be cured. So it's a different balance. So I think, we need to find something effective that's well tolerated, that's easier to take, and that's when I think we're actually going to be able to make better advances in terms of reducing the risk of uveal melanoma coming back. There are some adjuvant trials out there right now. I know there's some trials of some different pill combinations. There's trials of nivolumab and ipilimumab. So people definitely are working on trying to find something that can reduce the risk of this coming back. I just don't think we're at that point yet with tebentafusp. And given that it's given weekly and you have to be an inpatient, it may not be the best option in terms of quality of life. But those definitely are active discussions that are going on among different groups kind of all over the world.
Thank you, Dr. Moser and Dr. Daud. I know that there was a couple of questions, really kind of asking to expand a little bit on some of the promising treatments if you're HLA negative. Do you mind expanding on those just a little bit?
Yeah, sure. So what uh, if you think about HLA, it's basically HLA stands for human leukocyte antigen, and it's one of these what's known as a multi-locus antigen, meaning that like for example, if you think of some some of our genes, they come in two varieties, like let's just say blue and yellow, or just two forms, but HLA has multiple forms, and so uh, it's basically a method that your body has to recognize foreignness. So, like for example, if I were to give a kidney to somebody, like let's just say if I was to give a kidney to Justin, his body would probably reject it because we are not matched for HLA. And that's what, when you give an organ or when you receive an organ, you've got to match HLA types with the donor. And if they're not matched, if they're mismatched, that increases the chance that your immune system will then attack those organs and reject them. And so when people say HLA negative, what that really means is you just simply don't have the most common HLA type. That's the 201 type. So it's like saying you've got AB positive blood instead of A positive. A positive blood is very common, uh, in the US. AB is not as common. Only 5% of people have AB. So it's basically a matter for us to figure out what those less common types are, and then start making tebentafusp versions, or tebentafusp targets a protein called GP100 that melanoma cells produce. But the reality is, melanoma cells produce a lot of other very specific proteins, and that could be PRAME. There's a trial going on with PRAME, PRAME. There's something called tyrosinase, which is the thing that gives you that skin color. And then there's uh, what are known as cancer testis antigens, like NY-ESO1, and numerous proteins that are produced only in melanoma cells, not produced anywhere else. They include things like MAGE, um, A2. There's a whole bunch of them. There's TRIP1, and so the thinking is that once you change the dextromer portion, the portion that connects to the HLA, that could be swapped out for a different uh, type of dextromer. You could still keep the CD3 portion the same, but you'd swap out the dextromer, and then essentially that could be applied to anybody, or even the less common HLA types. Now, of course, I'm making it sound like it's simple, but and of course it's not that simple, because these have to be tested. And uveal melanoma has the further problem that, because of its rarity, you can't simply do a trial with 700 patients each time you have a rare. It's just because you just don't have that many patients who might have rare HLA type, right? So you're probably going to have to make these things specifically for a given patient. But conceptually, there's no problem at doing that. It's just a question of getting down to the work and actually getting to it.
Mm. Thank you. And so in that case, and Dina, I think this kind of goes with the question that she has is it important to be HLA tested?
Yeah, I think it is great to. Yeah, yes, I think it is important to be HLA tested, and probably everybody with uveal melanoma should be HLA tested,
Mm.
both to see whether you can be a candidate for tebentafusp, and also if you're not, then at least we know what you have, and then hopefully in the next few years we have these other types of reagents available that can, that could be used to target your specific type uh, of uveal melanoma.
Thank you. Thank you so much. And thank you, Dina and Suzanne, for those questions. We do have a couple more. We've got about 7 minutes here. So Helen Boyer sends into the chat here your thought for using Tebby in combination with another drug in the near future. What are your thoughts on that?
I mean, I think it's a great idea, and probably what people think today is that even if you manage to get T cells into a tumor, eventually those T cells might get exhausted, and that's just a word that's used. Doesn't literally mean that your T cells are, have done too many reps and they need to put the. It doesn't. That's not literally what it means. But I think what it means is that they kind of run out of gas in the sense that they don't have the same killing potential as they do when they're fresh off the streets, or fresh off your blood. And so the way to de-exhaust T cells is to use these drugs like pembrolizumab or nivolumab or relatimab, which I
I'm
think
glad
is
I'm
the
not the
way.
only one that can't pronounce some of these words. So thank you.
So probably you can add some extra juice to those T cells by combining Tebby with. I like the way I like that. I like calling it Tebby,
Too.
but that somebody referred to. So that makes sense that a combination should be more effective than just tebentafusp by itself. But there are these safety issues though. Is it going to add to the side effects, and is it going to cause more problems? Which we don't know the answer to that.
Thank you. Dr.
Yeah,
Moser, do you have any thoughts on that?
yeah, so I completely agree. Tebentafusp, like Adil said, brings the T cell into the tumor, which is what we want. And then the next kind of step of that is, well, what are those T cells doing? Are they being suppressed? And we can sometimes unsuppress them by using nivolumab, ipilimumab, Keytruda, pembrolizumab, just like Adil said. But there's also a new class of medications coming out there that actually act, well, not a new class, but a re-emerging class of immune therapies like cytokines and other agonists that actually give the T cell gas. So now we actually have molecules where we can unsuppress them, but also activate them. And I think there's a lot of interest in trying to figure out, or a lot of interest and a lot of promise of trying to figure out how can we ramp up those T cells once they get there. The big questions is how can we do that safely? And so we'll have to wait for trials to kind of show that it's effective in safety before I think it's going to get really, kind of widespread use. And I think doing these combinations are great options for patients who have the HLA-0201, right? Combining something with tebentafusp or Tebby is a good option for those patients. I know someone else asked, well, what are the options if you don't have that HLA type? And there still are a lot of emerging options out there. There's a lot of new immune therapies that are coming to the clinics. There's injections now where we can do a CT-guided injection into a liver tumor that can actually cause inflammation directly in that tumor. Now, these trials aren't specifically for uveal melanoma right now, but these trials are in early phases. And so although we're making progress for certain patients with the right HLA type, there are another wave of immune therapies and even targeted therapies that are applicable and coming in these early phase trials for patients with all HLA types. And that's also true for non-immune therapies. We're starting to see a lot of pills and other drugs that we think may be able to target the mutations that drive uveal melanoma in different ways. So, GNAQ They can activate different proteins such as TED and YAP, and we're starting to see TED inhibitors come to trials and come to the clinic. We'll see if they're effective or not. And we're starting to see that, with some other targets as well. So I definitely think there's a lot of emerging targets and drugs that could be applicable to uveal melanoma that we're starting to see in the phase 1 clinic. We just hope they're effective and safe. And then the next step would be move them into uveal melanoma patients in the setting of a clinical trial.
Perfect. Thank you so much, Dr. Moser. And thank you, Helen, for submitting your question. We have a few more questions. We're actually going to move into the break just a little bit to get all these answered. So I know they're really important. And the next one comes from Roger Shore. It says, along with the yearly MRI, are there additional tests, blood or genetic, that can be done for a better look at where we are as a potential metastatic outcomes?
So as of now, no. I think a lot of people are trying to develop blood tests, but those are not mainstream right now. So really the best way we can determine risk is with a biopsy on the primary tumor and doing genetic testing on that, and then the yearly MRIs.
Dr. Daud, do you have any thoughts on that?
Yeah, totally agree that we do tests like liver function tests and like LDH and liver enzymes, but those tests just tell us if there's a disturbance in the liver or there's some type of inflammation in the liver. They're not specific to uveal melanoma per se, which I think that's the question. That is there some way to tell whether the cancer per se is out of the box, and those tests are not specific enough. Like Justin was saying, just for us to be able to say if the cancer is out of the box. But I do think that very soon, maybe in the next few years, there'll be tests because people are looking at things like circulating DNA. And so once you know your mutation, once you know that you have a GNAQ or G11 mutation, you could check and see whether you've got cells in your blood that have the same type of mutation. And if you do, I guess that could indicate that you got some uveal cancer cells floating around in your blood, and that could be a risk factor for developing metastases in the future.
Thank you. Thank you so much to both of you. And thank you, Roger, for submitting your question. I've got one from Nikki Doyle, and she says, do you know of any doctors or drug companies who are developing other drugs like Tubby for folks who are HLA negative?
No, that's a great question, and would have to research that a little bit, and before I could give a straight answer to that. I think, uh, like I was saying, conceptually that's not a problem, but are people actually doing this in the here and now? Which is what the question is.
Mm.
I'm not sure about that. I feel like there might be, but I would have to look into that more.
Sure. Dr. Moser?
Yeah, I'm not aware of any drug that specifically works the same way as Tubby. But there are other companies that have drugs that are looking at uveal melanoma. I think Foghorn Therapeutics has a phase 1 trial of a BRD inhibitor, I believe. I think a lot of the drug companies that sponsored this event have drugs that they're looking at trying to get involved. So there's definitely companies looking into this, and there's definitely companies that have drugs that could be applicable to uveal melanoma that we're all trying to convince to come into uveal melanoma. But in terms of working via the same mechanism of Tubby, that I'm not aware of, but I could be wrong.
Okay. Thank you so much. And our last one comes from Nancy Beery, and we'll take this as the last question. We may have already addressed this, but Tubby is phase 3. Is it open for researchers to give to their patients that have not participated in phase 1 and 2 for tebentafusp?
I believe it's pretty restricted right now because the company that makes it, Immunocore, is relatively small, and they don't have. That's what I've heard, is that they don't have the resources to really extend it. And I know we did not take part in the phase 1 and 2 trials, so we're not able to offer it to our patients, and we are basically referring our patients who need TEBI to go into to contact other. Yeah, it's actually kind of a problem to get it right now.
I agree, but I chatted with the company, I think about a week ago, and they are hoping to restrict that or de-restrict that a little bit. And so hopefully people like, Adil and myself who were not involved in the trials will be able to give this before It's FDA approved on an expanded access protocol in the near future. So access should be getting much better to this shortly.
Well, thank you so much to both of you. I know that this has been super helpful for everyone that's been watching today. And again, if you want to learn more about Dr. Moser and Dr. Daud, feel free to check out their speaker profiles. We have some contact information in there. And again, Honor Health, I think, is going to be around for a little while in their exhibitor booth. So be sure to check them out. And again, thank you both so much for sharing that information.